plan for creating awareness about venous diseases in India. And a special thanks to Dr. Bedi, President of VAI, for his support for conducting these series. Today's topic of discussion shall be what more should a family physician know for diagnosing, treating, and managing varicose veins. And we have a very special guest with us here. Please welcome Dr. Shoaib Padaria. Welcome, sir. He's an interventional cardiologist and phlebotomist, director at the Department of Vascular Sciences, Jaslok Hospital and Research Center in Mumbai. Dr. Shoaib Padaria is regarded as an esteemed cardiologist with over 34 years of experience in cardiovascular treatment. He's a pioneer of endovenous laser treatment for varicose veins in India and the founding member and past president of the VAI Association, Venous Association of India as well. Dr. Padaria is an expert in laser treatment for varicose veins, coronary angiography, permanent pacemaker implantation, peripheral angiography, and hyperbaric medicine as well. So over the 30-35 minutes, you will be listening to Dr. Padaria. So over to you, sir.
Thank you, Radhashika. Thank you very much. And thank you, Doc Plexus, for giving me this opportunity to address the 20,000 plus members of Doc Plexus. I'm sure all of them are not here today, but maybe they'll take an opportunity to listen to us or watch our recorded program later. So let me start by sharing my screen. And great. So friends, good evening to every one of you, and welcome to this program. What I'm going to do today is something which is very basic, but at the same time very practical and very useful to all of us when we deal with our patients. And that is what should every family physician know about varicose veins? Now, you're probably aware, still statistics say it all, that almost 20% of all adults suffer from varicose veins. And if you split it up, you'll see that 25% of all women and 15% of all men suffer from some form of varicose veins. And as age increases, obviously the prevalence of varicose veins also increases. We don't know much about the epidemiology of varicose veins, but we know some things. That in the West, the prevalence of chronic venous insufficiency or severe venous disease is about 5 to 10%. On the other hand, in the East, especially in India, the prevalence is slightly higher at about 15%. On the other hand, when we look at severe varicose veins and its complications like a venous ulcer, in the West, it's about 1% prevalence, but in India, the prevalence is as high as 2.5%. And therefore, data suggests that chronic venous disease is a comparatively greater problem in a tropical country like ours. Now, before we go into the details, I'd like to discuss a little bit about the venous system of the lower limb. All of you are aware of it, but I'll just take a minute or two on the basic anatomy. We know that the venous return of blood goes back to the heart by two types of veins. The deep venous system, which takes back 90% of the blood back towards the heart. And then we have the superficial venous system. The superficial venous system comprises of the great cephalous vein. And as you know, the great cephalous vein starts from the inner side of the ankle. And then this basically goes all the way up to the groin and empties here into the femoral vein. And that valve here is called the saphenofemoral valve. The second vein, which is the superficial vein, is the short cephalous vein. This starts on the outer side of the ankle, goes behind the knee joint in the vast majority of patients, and enters into the popliteal vein. And there is a valve here, which is called the saphenopopliteal valve. And the great cephalous vein and the short cephalous vein together are responsible for taking about 10% of blood of the legs back towards the heart. Now, how does this venous blood from the legs go back to the heart? And this is the function of the calf muscle pump. When the calf muscle pump contracts, it basically squeezes the veins and this pumps this blood upwards. And because there are presence of one-way valves in the veins at various levels, this prevents the blood from coming back during relaxation of these muscles or when the patient is in an upright position. Now, when this valve gets damaged for any reason whatsoever, then the blood comes back from the deep veins through that leaking valve into the superficial vein. And as the pressure in the superficial vein increases, the vein becomes tortuous, dilated, and that's what we call varicose veins. So now we'll understand that the basic problem in the development of varicose veins is a leaking venous valve. In the vast majority of patients, this leaking venous valve is hereditary or congenital and present since birth. And in few patients, it can be because of trauma or other associated reasons. Now, if the saphenofemoral valve in the groin gets damaged or leaks, then obviously the great saphenous vein will show varicosities as seen in this picture. If the short saphenous vein is involved because of the leakage of the saphenopopliteal valve, then you will see varicosities behind the knee joint as seen here. There's a third point type of valve which is very important, and this is called the perforator valve. You know, between the superficial veins and the deep veins at various levels in the legs, there are some communicating veins, and these are called perforator veins, and they carry the blood from the skin veins to the deep veins. And in these veins, there is a valve called the perforator valve. If this valve starts leaking, then you will get this sort of pigmentation around the ankle. So there are three types of basic valve refluxes which could occur. Now, varicose veins basically is a progressive condition. It is never stable because increased pressure in the vein over a period of time will give rise to problems. So initially, a patient may have simple varicose veins. Later on, he'll develop swelling of the legs. With increased pressure and time, there'll be skin changes, especially around the ankles and the lower legs. And lastly, the patients will land up with skin ulcers. How do you actually objectively define these conditions? So therefore, we have a particular formula. CO relates to no visible signs of veins. C1 refers to basically spider veins, tiny veins, which are very commonly seen in so many people. C2 refers to varicose veins. And anatomically, varicose veins are those which are larger than 3 millimeters in diameter. C3 disease refers to swelling around the ankles or edema. C4 refers to the various skin changes which occur. C5 refers to a healed venous ulcer, and C6 refers to an active venous ulcer. So this is the way we actually tabulate the data on patients of varicose veins. What are the symptoms that can occur due to varicose veins? First of all, remember that almost 50% of patients with even significant varicose veins may have no symptoms at all. They may just have large bulging veins, but they are pretty okay. But the other 50% could have various symptoms. This could be like tingling, aching pain, a sensation of swelling or burning, muscle cramps, especially at night, very common in the calves, throbbing pain, especially in the thighs, heaviness of the legs on prolonged standing, itching of the skin around the ankles, which is a precursor to formation of a venous ulcer. Restless leg syndrome. Patients keep on moving the legs up and down throughout the night. And one of the causes of this is underlying varicose veins. Tiredness of the legs and fatigue of the legs. How do you actually make a diagnosis of varicose veins? Of course, clinical diagnosis is very easy. You have seen that their large dilated veins are there. But remember, in many patients, these dilated veins may not be visible from outside. They are dilated within. And therefore, the diagnosis is basically made by an investigation, which is today the gold standard, called the venous Doppler ultrasound. Now, this venous Doppler ultrasound is, of course, available nowadays everywhere. It's essential to map the extent of vein disease and also to show that there is actually leakage in the vein, which we call reflux. Now, when we evaluate the varicose veins, something which is very important, and you should tell your radiologist who's doing this study, that the study should be done with the patient in the standing position or in the inclined position. Why is that? See this chart here. If you see in the standing position, the size of the vein may be 1 centimeter. As soon as you lie down, the blood goes back towards the heart, the vein collapses, size becomes only 0.5 centimeters. And if you elevate your leg, the size may even decrease further. And therefore, we normally do a venous Doppler like this in an inclined position, although the ideal position should be in the patient standing up with the radiologist doing the Doppler, the patient standing on such steps. They're very essential in actually determining the size of the veins in a venous Doppler study. Now, why is it important to treat varicose veins? Obviously, every patient, just because he has dilated veins, doesn't need to be treated. There are some reasons to be treated. One is cosmetic reason. A lot of people don't like these large veins. They want to get rid of them. It's not only ladies, but even gents. They don't want these veins to be seen. If the veins are large enough, it's a good reason for treatment. But apart from that, there are other medical indications: leg pain, edema, pigmentation, status dermatitis, ulceration, and large, long-standing ulceration can even lead to malignancy. Bleeding from the veins, very common, and you must remember that bleeding from varicose veins is most of the time absolutely painless. Can occur at night, can occur during a bath. Patient may not even notice the bleeding. Superficial thrombophlebitis, very common in patients with varicose veins, especially in the corona situation now, when the thrombosis of blood is a very common problem we all know about. Deep vein thrombosis can occur in a patient of varicose veins, which can lead to pulmonary embolism. Not only that, even if you don't have these complications and you have large varicose veins, these can lead to a decrease in quality of life. It has been shown that there's a reduction of almost 52% in physical, 54% in social, and 48% in psychological quality of life in patients with significant varicose veins. Unfortunately, varicose veins treatment in India, almost 80% receive no treatment at all. Only 10% of diagnosed patients receive stockings. Drug treatment is given only in 5%, and actual definitive treatment, only 1% of patients in this country receive that. So you will see that there's a great scope for patients to be treated for varicose veins in this country. So how do we go about treating varicose veins? The first thing that is very important is lifestyle modifications for the patient. You must see to it that they exercise regularly with a focus on exercise that work their legs. They must control their weight, because obviously the more the weight, the more the pressure on the veins, the more the leakage of the valves. Let's tell them not to cross their legs when sitting, because you're pressing on the veins, increasing the pressure. Also, while resting, like for example, you're sitting at home watching television, try to elevate your legs. If the patients have to stand for long periods of time, shift the weight from one leg to the other every few minutes. And if the patients have to sit for a long time, especially nowadays, youngsters work from home or computer operators, then if you're sitting for long periods, get up every few minutes, walk around for 5 minutes, and come back and sit down again. So once your calf muscle works, all the accumulated blood in the calf goes back up towards the heart. Stockings also are very useful. We have special support stockings which are prescribed to slow down the progression of varicose veins. Yes, they give some symptomatic relief, but we also know that they have to be worn every day to be effective. And most importantly, they do not cure the problem of varicose veins. Varicose veins will still progress over a period of time in spite of wearing compression stockings. So while there are some advantages of stockings, like they can relieve symptoms, the disadvantage is that poor compliance, especially in our hot tropical climate. Also, they are quite expensive and they last only for 3 to 4 months. You have to buy new ones. It's quite difficult to wear. Sometimes it takes 20 to 30 minutes to put on the stockings. In elderly people, they may even need an assistant. And of course, if you have severe peripheral arterial disease or patients with cardiac failure, it is contraindicated. Now, these stockings which are there should not just be bought like regular stockings. They have to be graduated compression therapy stockings. What does this mean? This means that the maximum pressure which is there should be around the ankle, 70% of the pressure should be at the region of the knee joint, and 40% of the pressure should be at the thigh. So that increased pressure from here and a decrease in pressure here allows the blood to go upwards towards the heart. You will understand if there's 100% pressure here and 40% here, you'll end up with severely edematous and swollen legs. Now, there are various types of stockings available in the market. Well, what you need are these. If a patient of yours has varicose veins, then you need what are called class 2 compression stockings. Write this down, it's very important. Why? Because the pressure should be between 20 to 23 millimeters of mercury. If your patient has significant varicose veins only below the knee, then you can give what are called knee length stockings. If the varicose veins are higher up also, then give thigh length varicose stockings. If your patient has severe varicose veins with swelling around the ankles, edema, then the above stockings will not work. Then you need what are called class 3 compression stockings. These are two stockings which are to be worn one on top of the other, and the pressure they deliver is 30 to 40 millimeters of mercury. So this is something you need to know, and these are the type of stockings you need to prescribe. And these stockings are to be worn every day, early morning, at least for 10 to 12 hours. They do not need to be worn at night. Very important. What about drug therapy? Are there any medicines for varicose veins? Oh yes, there are plenty of medicines. There are so many medicines available. So flavonoids, oxyrutin, calcium domicelate, acid, rusas, ginkgo biloba, you name it. However, the only drug which has been proven in multiple international trials again and again to have some benefit is what is called micronized purified flavonoid fraction, available in this country as Daflon. This is not only useful in varicose veins, but also has been shown to be useful in the healing of venous ulcers. Daflon decreases the leg pain by almost 73% of patients over a period of 3 months. It decreases heaviness by around 55% and decreases nighttime cramps by almost 86% in patients. And the dose should be in significant varicose veins 1000 milligrams once a day. But if patient has venous ulcer, then 1000 milligram tablet twice a day. Minimum period 3 to 6 months. You can see here the swelling of the legs also decreases significantly. In fact, we did a study. I was one of the authors, which was published in the JAPI, Journal of Association of Physicians of India in 2016, in which we clearly showed that flavonoid drugs strongly recommended in all stages of varicose veins are useful in decreasing the symptoms. Apart from that, in our country, we also have homeopathy and Ayurveda. And there are some good drugs available. In homeopathy, there is something called Calcarea fluor, Himalis, and fluoric acid. And Ayurvedic, there is Brahmi, Chasad, and Chandravan. These also are good drugs. I don't have much details on them. I've tried them in some patients, and they do seem to work quite well. However, what are the definitive procedures for treatment of varicose veins? There has to be something in which we say we get rid of these varicose veins and give this patient some extremely good relief. How do we go about doing that? So first of all, the old methods were the surgical methods, vein ligation and vein stripping. Nowadays, of course, 99% of cases all over the world are done by non-surgical methods. In our country, because non-availability of these methods, I still think a large number are done by surgery, but more and more are being done by the non-surgical newer methods. There are these two types of newer methods: the thermal methods, which include laser, RFA, steam, microwave, and HIFU, and the non-thermal methods, sclerotherapy, Clarivane, Phlebograph, and glue. I'm going to discuss all of them in detail. Now, as far as surgery for varicose veins is concerned, the ligation and stripping, which we all know about, was done in the past, but obviously we also know there are lots of side effects of surgery. And surgery can leave permanent scars. With anesthesia, there's always a risk of heart and lung complications, wound infection, inflammation, swelling, redness can occur. And a very common complication of surgery is the damage of nerve fibers around the veins, which can lead to pain for many months or years. There's something called a microsurgical technique, which is called microphlebectomy. This we also commonly use basically for tiny varicose veins, and we use a very tiny needle and an applicator to remove these tiny veins under local anesthesia, and they can, of course, give very good results. They leave very tiny puncture marks, which can be seen for a couple of months, and then they disappear after that. However, the newer non-surgical endovascular techniques have taken the world by storm. And in the last 20-25 years, more than, as I said, 99% of cases abroad are done by these techniques. These are all office-based techniques, all performed using just local anesthetic. We use either heat or chemical ablation of the veins to close the veins. There is no downtime. In fact, most of our patients can resume the work the very next day, and they are covered by most insurance plans. However, something you must remember when treating varicose veins by endovascular methods. Most patients who will come to us, will come to you, will a combination of large varicose veins and smaller radicular and spider veins. And therefore, different treatment methods may be best for each type of vein involved or for different sized veins. And therefore, in most patients, more than one treatment will have to be done at the same time to treat all the veins. In general, you must treat the larger varicose veins and any associated reflux or leakage first before you treat the spider veins. And especially if you have venous ulcers, you must not only treat the larger veins, but also the perforated veins. I will discuss that a little later. So let's first discuss the non-thermal techniques. That means the techniques which don't use heat. The first technique is sclerotherapy. What is sclerotherapy? Sclerotherapy is injection of a chemical solution into the vein, which selectively targets and damages the vein wall, leading to spasm, fibrosis, and eventual closure of the vein. And we use two chemicals, sodium tetrahedral sulfate or polydocanol. In South America, they also use a high concentration of dextrose, but that can be very, very painful. So how can this be done? There are two types. You can use the liquid sclerosing solution, and these are usually injected with very, very tiny needles, about 30 to 33 gauge needles into the spider veins, and they can give excellent results. Or you can make a foam out of this liquid. And when you make a foam out of this liquid and you inject it into the vein, it stays for a longer time and gives a better result. And I would like to show you a little video here of how we do this. Okay, so video is going to work now. So you can see here that is the patient's calf and the lower thigh, and you can see multiple reticular and spider veins with a very thin scalp vein, which we put inside, or we can use a needle. And once we are inside the vein, you will see a little bit of blood coming back. Once you do that, then we prepare this foam solution with 0.25% polydocanol solution and very gently inject it into the vein. As soon as you inject it, you will see that the color of the vein changes. The blue veins immediately become white. Then once a little bit is injected, you take a little gauze piece and you squeeze that solution into all the veins. And you will see that the color of the veins closes because the veins go into spasm and close immediately. The procedure is then repeated one by one in different areas. And within a matter of few minutes, you'll have treated all the veins. The results of sclerotherapy can be quite good. This is a patient who came with multiple varicose veins here. And as you can see, 1 month later, you see the legs look quite good. So here I use this a lot for, Bombay is the Bollywood capital here. We have a lot of film stars here, media personalities. And so we do this sort of work and a lot of them to give quite good results. There's something called mechanical ablation for varicose veins, another new technique. Now here there's a technique called phlebogriff. Here again sclerotherapy solution is used, but in this sclerotherapy solution, when you inject sclerosant, you also irritate the vein. First, you puncture the vein with a needle, you put a small guide wire. Over that, you put a catheter. This is done under total local anesthesia. So once you've put that catheter into the vein, which is the dilated vein, of course, and you can use this for slightly larger veins. Earlier, we talked of smaller veins. Phlebogriff can be used for larger great cephalic or short cephalous veins. Once you have introduced the catheter, and you will see that the sclerosant will now be injected through that catheter. As you inject it and you pull back the catheter, you'll see the catheter has small metallic pins at the side, and they rub against the wall of the vein, causing the spasm of the vein. And once the vein goes into spasm and you inject the foam, the result is very, very good. And the entire procedure should not take more than 10 minutes. Also a good procedure for treating varicose veins. Similar procedure is Clarivein, but here instead of those metallic hooks, you have a small metallic wire which rotates very rapidly, again causing spasm of the vein, and we inject the sclerosant and give good results. So here you see pre-treatment, you see how nice it is here, and post-treatment, the varicose veins have disappeared. Something nowadays is quite commonly exposed to every patient is glue therapy. So what exactly is this super glue for varicose veins? Super glue is a chemical solution called cyanoacrylate. It's available from United States called Vena Seal and from Turkey called Vena Block. So just like I showed you earlier, you introduce a catheter under local anesthesia into the vein. Here also you introduce a catheter into the vein, and then you inject this glue. This is all done under ultrasound therapy. So glue basically is a very simple procedure to do, and unfortunately, it has some, of course, some effects. Benefit. It has no downtime, pain rating is minimal, does not require tumescent anesthetic, can be performed in 20 minutes, and importantly, no stocking is required after treatment. However, you must remember that drawbacks also are very great. It cannot be used in very superficial veins. Why? Because the glue basically thickens and forms a very cord-like structure in patients, which is very superficial and can be very, very painful for many months. Not only that, this can also lead to allergic reaction in some patients, which occasionally can be fatal. Thirdly, this glue, when it actually solidifies, it becomes like cement. Now, if a part of this breaks and embolizes, it can create a major issue because it cannot dissolve and can lead to very severe DVT and very severe pulmonary embolism. And so glue, although it has good benefits, remember it should only use in very selected patients patients who have only a deep refluxing great saphenous or short saphenous vein, patients who are very obese, patients who are allergic to local anesthetic, and so on and so forth. It is definitely not for everyone. Now let's come to the thermal techniques for varicose veins. There are 5 thermal techniques: laser, RFA, which is called radio frequency ablation, steam therapy, microtherapy, microwave therapy, and HIFU. Of course, laser is the most common treatment procedure in the world, with the best results shown so far over the last 25 years. Now, we performed the first test of laser in this country in January 2003 at Jaslok Hospital. 9,000 in 19 years, we've done more than 18,000 cases, one of the largest series. How do we do this laser treatment? We use a small portable laser machine, which is called a diode laser machine. And this is a 1470 diode laser, which basically means the wavelength generated of the laser is 1470 nanomicrons. And this laser energy, which generates heat, is delivered via catheter, which can be a bare laser fiber, which can deliver the energy directly in forward, or by a radial laser fiber, which delivers the energy circumferentially in the vein. This is heat energy. The other method of heat energy which is common is called radio frequency ablation. Now, instead only the tip of the fiber delivering the heat, you have a 7 centimeter long heat generating element which delivers the heat to the surrounding vein wall and causes the damage to the vein wall and permanent closure. This is the equipment which is basically used, very similar to the equipment we use for a coronary angiogram. And let me show you how, by animated video, how this is done. Now, this is the great saphenous vein varicosity. Obviously, the leakage is coming from top, and you see these large varicosities here. What we'll do is puncture the vein somewhere here, go all the way up into the vein up to the saphenofemoral valve, close this entire system of vein. Once you close this vein, the leakage coming here into these varicosities will stop, and obviously all these will collapse. Let's see how this can be done. So as I said earlier, the entire procedure is done under local anesthetic. I think video is taking a little long to start.
It's all right. I think.
No problem. It'll come.
Yeah.
So the idea, basically, you will see the video in a short time, I'm sure. But let me do one thing. Let me show you the video separately, if possible.
Yeah.
Okay. Fine. So you'll see the video now. So the entire procedure is done under local anesthesia. And first you do a sonography to map the entire vein. As I said,
Sir, the video is, I'm so sorry, sir, the video is not visible.
It's not visible.
You'll have to share the video separately, probably, because you're sharing the screen of the presentation.
All right. I'll do that.
So maybe you could stop sharing and then share again.
No, that's true. But where is my screen? I've lost my screen, I think. Okay. Screen doesn't come up, I think. Okay, very good. Got my screen now?
Yeah.
Great. Okay.
Perfect, yeah.
Perfect. So you first do a sonography, as I said, to map the entire vein. And as I said, we should enter the vein from below. After giving local anesthesia at that particular site, the skin in that site is numbed. Then you use an 18 gauge needle to enter the vein. As you can see, it enter the vein here. And you will see this needle entering the vein. That's the ultrasound of the vein. You can see that black circle. So you got blood coming out. So you've entered the vein. Through that, you put a small guide wire, similar to an angiogram. And under ultrasound control, you see that the guide wire is now in the vein, across the saphenofemoral junction. Now over that, you put in a sheath, and through the sheath, you put in a laser fiber. You can see the laser fiber gradually advancing upwards. And here, as you can see, saphenofemoral junction on top, the laser fiber coming out of the sheath, it should be 2 centimeters away from the junction. Once that is positioned, then around the vein, you give a little bit of local anesthetic. Now, this is the most important part of the procedure. This is called tumescent anesthesia. So when you inject this local anesthetic, it first of all covers the entire vein all around. Secondly, it also compresses the vein over the laser fiber. So once the heat comes out from the tip of the laser fiber, it directly acts on the vein wall and does not damage the surrounding. You start giving laser energy, and as soon as you do that, the vein immediately starts collapsing. And you keep on withdrawing the fiber step by step. In the matter of a few minutes, the entire vein is now closed. So as you can see from here, you bring the fiber all the way down and the vein gets closed, and you bring it all the way down to your point of entry, you remove everything, and all that you're left behind is a small puncture mark at the site of insertion. And that's all there is. You put a small little bandage there, make the patient wear a stocking, make him get up and walk for half an hour, and the patient can go home. And this is the sort of result you get. So as you can see here, before laser treatment, the large varicosities, once you close the upper vein and the flow is stopped or the reflux is stopped, then you'll see that the varicosities all disappear. Here's a patient with large varicosities in the upper thigh because of a mid-thigh perforator. Once you close that section of vein, again, you'll see I've closed it from down here all the way up, and the veins all disappear. See these large veins, a bunch of veins in the groin, a bunch of veins just below the knee joint, and also a bunch of right at the ankle. This all is because of a single great saphenous vein giving rise to tributaries. You close the entire great saphenous vein, and there you see the veins all collapse with a good result. Huge varicose veins here. Now people will say, how can you put a laser fiber through this? You can't, because this is only a tributary. The main vein is actually below that, going from below all the way to the groin. You close that, and these become an empty vein, and they disappear over a period of time. Of course, having done that, I will also do microphlebectomy here and just take this vein out with a small needle puncture. See this patient who had large varicose veins coming from a tributary of the great saphenous vein, crossing the knee joint. We finished the case, and this patient is still on the table, and the veins have all totally disappeared. This is a lady a Gujarati lady from Ahmedabad, who was very keen to go for the Garba dances, but had these ugly looking varicose veins. These are the varicose veins arising from the great saphenous vein, going along the lateral aspect of the thigh. All we needed to close the upper part of the great saphenous vein, close the leakage, and here we injected sclerosing solution, and 2 months later, you will see that the veins have fully disappeared. Another area where we can use these endovenous treatment therapies, especially laser ablation, is in treatment of a complication of varicose veins, which is treatment of venous ulcers. Why do these venous ulcers occur? One of the commonest reasons of venous ulcer occurring is something called perforator vein reflux. A perforator vein, as I said earlier, is that which communicates between the superficial and the deep vein. And normally, the blood would go from the skin vein to the deep vein. But when the valve in this vein is damaged, then the blood will come in the wrong direction, directly onto the skin at high pressure, and cause damage to the skin. And this will cause an ulcer formation. So if you can close this perforator vein, then obviously these problems will be taken care of. How can we close these veins? One is you can directly inject a sclerosing solution under ultrasound guidance into this perforator vein. However, this is a short-term effectiveness. It tends to open up again, and also a high rate of recurrence and high risk of DVT. Nowadays, people also inject glue, but again, the problem is prolonged thrombophlebitis and the risk of DVT. So one has to play safe. Of course, we can properly cannulate this with a laser and effectively give laser only in the perforator vein, making sure that the deep vein is not involved. And this gives excellent results in cases of venous ulcer. Here's an example of a 6-year-old non-healing ulcer. This patient had perforator veins just above the ankle and also leakage of the great saphenous vein. I closed both the great saphenous vein with laser and the perforators. They result at 1 month, and this is the result 2 months after treatment for a 6-year-old non-healing ulcer. This is a non-healing ulcer in a marathon runner, again because of perforator veins. And once we closed it, the veins closed here. This is a picture from 2000, and the patient is still doing very, very well. This is a patient who is a liftman, stands for long periods of time, a complex venous ulcer, non-healing. Again, just close the perforators in this area with the great saphenous vein, and the ulcer healed in a matter of 6 weeks. What are the other methods of heat ablation? I talked about laser and RFE, something called steam. How does steam work? It works by heating the veins with steam to a maximum temperature of 120 degrees centigrade. And this steam is ejected into the vein by the tip of the catheter here. The advantage is no expensive equipment or fibers are needed. All you need is generation of steam. The problem is that equipment is not easily available and no major trials have been done regarding the effectiveness. Microwave ablation is something new. I have had the honor of doing some of the first few cases in this country. This was a machine introduced about a year and a half ago. The fiber is more flexible than a laser fiber. It generates higher energy than a laser generator, and it definitely delivers slightly better results. Unfortunately, it's a very expensive procedure. So until the costs come down, I think we will stick with lasers. The future, however, is this: high intensity focused ultrasound. You know that high intensity focused ultrasound is already used in various clinical areas, especially like uterine fibroids. It's also now used for varicose veins. It's totally non-invasive procedure. You use this huge probe to generate ultrasound energy, which is highly focused, penetrates the skin, directly goes up to the target vein, and there it hits the target vein and causes a permanent closure. So there is no need of anesthesia, no need of puncture of the vein, nothing. However, unfortunately, currently the device is very large, very cumbersome, very expensive, is still in major clinical trials. We expect in the next 3 to 4 years that this will be the treatment of choice. Having said all this, are there any potential complications? Like any medical treatment, obviously, there are potential complications, especially if the veins have not been studied properly by proper ultrasound and the person is not well experienced. So the training of the person doing the procedure is very important. Still, there are less than 1% of complications. Infection, like in any surgical case, pain over the vein, which can last for 3 to 4 days, bleeding, rare, I've not seen it, bruising, but then the bruising normally tends to disappear within 2 to 3 weeks. With the newer equipment, we rarely see bruising nowadays. Nerve damage, one needs to definitely take care of. If laser is not done properly, if proper anesthesia is not given, the nerve goes along the vein and you can damage the nerve. So be very, very careful. Redness or swelling of the vein, what we call thrombophlebitis, is sometimes seen with antibiotics, anti-inflammatories. This tends to disappear. Blood clots, especially DVT, we're always worried about DVT. Luckily, the reported incidence of DVT is 0.04%, and that too in very large veins. So that is almost negligible. If you take good precautions, you will not get any DVT. Burns. This used to occur with older equipment, with newer equipment, and with good amount of anesthesia. Burns I have never seen in the last 20 years of practice. So friends, I tried in this short time to share with you a few points which every family physician should know, because when we as specialists see a patient and talk to them about varicose veins, they obviously go back to their family doctor, and that's where the family doctor needs to know something more about varicose veins, so as we can be able to share with the patient whether what is happening is really correct or not. So in conclusion, as far as the endovenous ablation treatments for varicose veins are concerned, as compared to surgery, you'll agree with me that these are safe, easy, non-surgical approaches to treatment of varicose veins. They don't require hospitalization unless, of course, you have Mediclaim, where in this country you need to stay in the hospital for 24 hours. There are no stitches, no scars. Patients can go home immediately after the procedure. There's no prolonged recovery time. In fact, 92% of my patients go back to work the next day, and reported success rates of 90 to 98% long-term. That when I say long-term, it's 5 years, make this the preferred mode of treatment of varicose veins. Thank you very much for attending this lecture. For detailed information of varicose veins in various languages, English, Hindi, Marathi, Gujarati, do visit our website. There'll be lots more information which you might be interested in. Thank you once again.
Thank you so much, sir. Very engaging lecture. And I do have a couple of questions. Sure. So if we could take those first.
Sure.
Yeah. So my first question is from Dr. Anand Kumar, who's a critical care specialist. He says how varicose veins should be treated in pregnancy.
Correct. Very, very good question, because this is something a lot of pregnant ladies come to us with. The first thing is that, as I said, that if you're born with weak valves and because of the pressure of the pregnant uterus, the varicose veins do tend to develop in pregnancy. But in the vast majority of ladies, the varicose veins will tend to disappear after delivery, usually in a matter of 3 to 4 months.
Okay.
So if they are small to moderate varicose veins, we should not really do anything. Having said that, you should make them wear compression stockings. Why? Because there is a very tiny chance that clots may develop in the stagnant blood in these varicose veins during pregnancy. And any clot developing in veins in pregnancy is very dangerous for the mother and the child. You know, definitive treatment for varicose veins during pregnancy, we rarely do unless the varicose veins bleed. If the varicose veins bleed, then those selected areas of varicose veins I will treat with laser, because laser is very localized and does not introduce any chemical into the body. We will not use sclerotherapy. During pregnancy, you don't want to inject any drugs into the body.
Sure. I think that answers the question very well. My next question is, this is regarding the chemicals or the combination, like the medicines used. I think you already mentioned it, but Dr. Neha Prasad wants to know how long can we give pentoxifylline tab, and is calcium dobecil effective, and what dose and duration for mild varicose?
So first of all, pentoxifylline has no role in the treatment of varicose veins. It is basically a vasodilator. It is given in peripheral arterial disease, but not venous disease. As far as calcium dobesilate is concerned, as I showed you in my chart earlier, this is one of many, many drugs which are available. You can use all of them, although MPFF is the most effective, but obviously MPFF may not be available everywhere, so calcium dobesilate is fine. If the patient has varicose veins, then these drugs are basically what are called venotonic agents. What do you mean by venotonic agents? They decrease the size of the diameter of the varicose vein. When they do that, they allow the valve in the varicose veins to approximate and decrease the leakage. And these therefore have to be given along with compression stockings for a minimum period of 6 months to a year. Okay, right. Having said that, one more thing, remember, when you're giving calcium dobesilate, please look at the patient's liver function, because this can affect the liver. So make sure that the liver function is normal.
Sure, sir. Thank you so much. Another question is from Dr. G. Manjunathan. Yeah, his question is, which specialty deals with laser treatment if varicose veins? Is it general surgeons, vascular surgeons, or interventional radiologist?
I think this is one of the best questions which I have been addressed with, and this is a burning question all over the world. As far as varicose veins are concerned, if I give you the statistics for the United States, almost 50% of the varicose veins in the United States are treated by interventional cardiologists. The next group of patients who treat them are the vascular surgeons and the general surgeons. The third group of patients we treat them are the dermatologists. And the last group of patients we see them are family physicians. Okay? So anybody who's trained in the venous disease can treat varicose veins. Now, for insurance reasons in the United States, there are various examinations which they undergo and certifications which they undergo. And this is open to people from all specialties. And once they get the certification that they've studied vein diseases, then they go ahead and treat it for medical legal purposes, obviously. In this country, the people who are trained to do interventions are basically two groups. One are the cardiologists who already do interventions for the arteries and the veins, and secondly, the interventional radiologists. Vascular surgeons now also have in their curriculum endovascular procedures as part of their training. So they are also now doing it. A lot of general surgeons who normally were in the past always the first to treat varicose veins are also getting trained to treat varicose veins by these endovascular procedures. Correct? However, for general surgeons in their curriculum in this country, it's not part of their curriculum or their training. So they have to get advanced training or attend some special course. I'm outlining this in detail because medico-legally, it's very important that you get training, you are certified, you have some documentation to prove that you have been trained to do endovenous treatment.
Thank you so much, sir. My next question. Thank you so much. My next question is from Dr. Azar, who says, kindly explain when and how to treat vulvocoly.
It's called vulvocele actually. So basically,
So
these
sorry.
are varicose
Yeah,
veins on the vulva. No, thank you. It's okay. These are varicose veins on the vulva. And so when you get varicose veins on the vulva, which is the private genital parts of ladies, as the family physicians know, uh, you will treat them only if the patient is symptomatic, if the patient has some complaints like pain, burning, etc. Otherwise, you tend to leave them alone. The most common reason for these to occur are basically deep venous pathologies. That means you have a problem in the pelvic veins, ovarian veins, or you have a blockage in the deep veins of the lower legs, like a iliac vein occlusion. If these are symptomatic, the patient has complaints, then the best way of treating them doing foam therapy, that is injection of a chemical foam solution into these veins using a tiny needle. And we try not to close all the veins at the same sitting. We do it step by step because sometimes it can be painful. And we call this patient back every 6 weeks and treat it in stages.
sure. My next question is from Dr. Usha Yadav, who says, what is the best option for varicose with perforator incompetence?
So as I said earlier, for perforator reflux, there are certain criteria. First of all, family physicians must realize, because a lot of the family physicians, as soon as they see perforator reflux on an ultrasound report, they'll send the patient to me for treatment. There are certain criteria for perforator veins. The perforator vein size has to be more than 3.5 millimeters in diameter. The reflux time has to be more than 500 milliseconds, and there has to be bidirectional flow. So once all these things, and also the perforator reflux has to be in an area where there's already skin pigmentation, a healed ulcer, or an active ulcer. And once you identify that, yes, these criteria are fulfilled, then the perforator has to be closed. You can inject foam sclerosant, it's very easy, but you will understand by injecting a chemical solution, it flows through the vein very easily into the deep system. So the effective action is only for a few seconds. And therefore, the long-term efficacy of this treatment is not very good. The perforator will open up again after some time. Second thing you can use is inject glue. Again, there are lots of cases worldwide that glue has gone to the deep system and caused deep vein thrombosis and permanent swelling of the foot. The most ideal therapy is two. One is you use directed laser therapy under ultrasound guidance. So you know the laser therapy goes only to that particular site and nowhere else. Or if all these things are not available, ask a good surgeon who's experienced to do a surgical resection of that perforator.
Thank you so much, sir. My next question is from Dr. Manjunathan again. He says, endovascular intervention, does it interfere with venous return in long run?
Very nice question. Again, more patients ask the question, doctor, you're going to take out one vein. How is my blood all going to go back? How am I going to survive? Will my leg become weak? So the first thing is that these all skin veins are normally supposed to take the bad blood up towards the heart. But this varicose veins is actually bringing extra bad blood into the leg. This blood has to go back some way, correct? So it's going back through the deep veins. And over a period of time, the deep veins are getting overloaded. So the more the varicose veins, the more the blood has to go back through the deep veins. Deep veins become overloaded over a period of time. Your deep veins also become damaged. And therefore, no, by treating the varicose veins, you are actually making the leg lighter. Less bad blood is coming into your leg is becoming healthier. Not only that, remember, what do you do for bypass surgery? The same vein in a normal person with a normal vein you're removing for using the heart. What happens? Nothing. So even if you remove all the healthy veins of the skin veins of the leg, nothing happens because, as I said earlier, 90% of the bad blood of the leg back through the deep veins. And the deep veins have a capacity of taking back more than 3 times the normal capacity, which is normal. So even if you give 3 times more blood to the deep veins, they are equipped to take it back. So if you take up all the skin veins, also nothing happens. So don't worry, the legs will become healthier.
Sure. One more question from Dr. Sameer Gupta, who says, laser and sclerotherapy, can they be done in the same setting?
Yes. So at our center and nowadays many centers in the country, we try to complete do the complete therapy for varicose veins of the leg in one sitting only. So we'll use a combination of laser, sclerotherapy, microphlebectomy, and so on and so forth to make sure that all the veins are closed in the same sitting, except for large number of reticular and spider veins. For this, we will call the patients back after 2 to 3 months. Why? Because once you close the main veins and the large veins, there's a very good chance that the smaller veins will collapse by themselves over a period of time, and you not need to close them. So we'll close them back later. Unfortunately, in the Western countries where the insurance plays a big role, patients are subjected to multiple procedures because billing can be done separately. So each vein is closed separately at a different time. That doesn't work for our country. We do everything at the same time.
Okay. So, sir, I do not have so far any more questions, but I think, so any message for our family physicians watching us here? Any closing remarks?
Yeah, so I think the people right in front in this major battle against varicose veins are our family physicians. It's not us, the specialists, but they are the ones seeing the patients first. And it's my goal to educate as many family physicians as possible on varicose veins and DVT and gangrene. Because if these patients are seen properly by our family physicians and identified, all the complications, long-term complications of varicose veins can be avoided. Not only that, remember today, 75% of the health information on the web is false information. Most of the patients who go and read whatever they read on the net is all false information. And therefore, it is up to our family physician to give them the true facts of what is the truth, what are the benefits, what are the risks, what are the complications, so that the patients can make an informed decision of how they can go further. So family physicians need to know all of this. And thank you very much for giving me this opportunity to address your group today.
Thank you so much, sir. And we received an overwhelming response to this webinar. Thank you so much to our dear audience for watching. And please do share if you have any more questions. Thank you, Dr. Padaria and your team for such an engaging session. We would love to host you again, and it was indeed a treat to listen to you, sir.
Thank you very much, and Happy New Year to everybody. Stay safe.
Thank you so much, sir. To our audience, stay tuned for our next VAI Master Series on 21st of Jan with Dr. Varia. We're talking about varicose veins therapies in various treatment options. So until then, please take care and have a great evening ahead. Thank you so much. Thank you so much, sir.